Good afternoon, everyone. Thanks for being on this afternoon. We're here today to talk about intimate partner violence in later life. So some of the objectives for today, we're going to define and recognize domestic violence, kind of as a refresher baseline. We're going to understand the prevalence of domestic violence in older adults. We're going to identify ways that IPVILL can present in survivors and discuss best practices for working with survivors of IPVILL. So first we're going to start off talking about domestic violence. So we're talking about domestic violence. We're talking about it in the context of being a pattern of coercive behavior used by one person to gain and maintain power and control over another in an intimate or former intimate relationship. It's important to note in Pennsylvania, our domestic violence definition does include family members as well. This is the traditional power and control wheel. Hopefully everybody has seen or is familiar with this wheel. The outer rim of the wheel defines violence or the threat of violence that's presenting in the relationship. Each spoke of the wheel represents different tactics that abusive partners may use to achieve the goal centered around these behaviors, which is power and control. Physical and sexual assaults or threats to commit them are the most apparent forms of domestic violence and are usually the actions that allow others to become aware of the problem. However, regular use of other abusive behaviors by the abusive partner, when reinforced by one or more acts of physical violence, make up a larger system of abuse. The power and control diagram is a particularly helpful tool in understanding the overall pattern of abusive and violent behaviors, which are used by an abusive partner to establish and maintain power and control over their partner. Very often, one or more violent incidents are accompanied by an array of these other types and tactics of abuse. So now that we kind of did this quick refresher, we're going to talk about it in the context of intimate partner violence in later life. So what is it? When we're talking about that, we're talking about any physical, sexual, or emotional abuse of an older person, age 60 and older. And PCADV is talking about it in a trauma-informed, survivor-centered approach. So Pennsylvania ranks fourth in the nation for being home to people over 50. Of the 12.8 million people who live here, about 2.9 million are age 60 and older. By 2020, the population of Pennsylvanians between 50 and 79 of age is projected to increase by 25%, and those 80 years of age and older to increase by an estimated 20,000. Over this past fiscal year, PCADV programs have seen an increase in services to the older adult population, serving 4,135 survivors. So why don't we use the term elder abuse? This is something that's really commonly asked when we're talking about intimate partner violence in later life. Terms, though seemingly connected, are very different. So elder abuse is often the umbrella terminology used when we talk about older adult abuse. But we have to note that it's broader and that we don't have stats on domestic violence alone because this often gets lumped into elder abuse. So that's why these are often seen as interchangeable. But when we're talking about elder abuse, IPVILL itself is defined as physical, sexual, emotional, and financial abuse by a current or former spouse, partner, or family member, where elder abuse is any physical, sexual, emotional, financial, neglect, or abandonment of an older adult, and it can be committed by any person or institution. So the relational element is missing from elder abuse that is specific to intimate partner violence in later life. Elder abuse, again, is used as an umbrella term when talking about older adult abuse, so it eliminates the distinct subset of domestic violence that exists in this population. Using the term elder abuse erases domestic violence from the older adult situation, and elder abuse cases are often handled by the Department of Aging. In Pennsylvania, we have two separate agencies. We have Adult Protective Services, but Older Adult Protective Services is specific to this population of 60 and older, and they use a medical model to provide protection from vulnerabilities, whereas our approach to IPVILL is the survivor-centered, trauma-informed approach. Does anyone have any questions about the differences between the two? Please feel free to use the chat if you do. So this is a new wheel. This is included in your handouts. This is something that we have developed. It was adapted both from the Duluth model as well as the National Clearinghouse on Abuse in Later Life called NCALL. They did a survey with survivors of violence, older adult survivors of violence, and they came up with their own version of the wheel to pinpoint tactics that were used that were missed by the Duluth model, that were specific to their older adult experience. So what we did was we combined the two together because, again, NCAL looks at things from an elder abuse perspective. So we wanted to bring it back to the domestic violence victimization that occurs and the tactics used in domestic violence relationships. So we merged the two together in a way that was encompassing IPVILL. So in addition to the tactics on the wheel, many abusive partners justify or minimize the abuse and deny that they're abusive towards older adults. Perpetrators of abuse in later life may make comments like, they're just too difficult to care for, or they abused me as a child, or blame their partner, or try to minimize the abuse by saying, oh, that person just bruises easily, or they only got hurt, because I was trying to help them get up out of the chair. That's why that happened. I didn't mean to hurt them. So a lot of these tactics can be written off by their own behavior as well. So we're going to take a look at each of these spokes to kind of walk through it so everyone can kind of gain an understanding both of the tactics that are used and how it's different, how domestic violence presents in this community, as well as getting familiar with the tool, the new wheel, so you can use it as a tool as well. So when we're talking about physical abuse, for people over 60 years of age, physical abuse can be more damaging and have longer lasting effects due to infection and other medical issues. Physical abuse can consist of hitting, pinching, forced medication, breaking bones, and controlling the range of motion. Another tactic that can be used against older adults is throwing oranges at them. If you throw an orange at a body, it will not leave a bruise but can cause severe internal bleeding. So it's an untraceable act of abuse that can be used against any population, but in older adults it's common as well. And when we're talking about controlling range of motion, this is, creating hazards or blocking access to doorways in order to control them from either getting in or out of a room. We just wanted to clarify what that meant too. So another new addition to our wheel is we added psychological abuse to the outer wheel. Traditionally it's just physical and sexual. We had added psychological because psychological abuse is a long-term manipulation that's used against an older adult survivor to make them question their capabilities and reality. So psychological abuse can consist of gaslighting or telling the older adult that the abuse isn't happening when it actually is. Using scare tactics, you're not able to make it on your own, which is undermining their independence, threatening to put them in a home, threatening to, take away their independence by saying, you need me here. That's kind of the long-term psychological abuse that can occur in IPVILL relationships. So when talking about sexual abuse, this is the most underreported form of abuse to be reported by older adults for several reasons, for things such as feelings of shame, guilt, and fear. So when we're talking about sexual abuse in the context of adults 60 and older, this includes sexual touching or molesting, caregiving, toileting, bathing, forced sexual acts, so forcing the older adult survivor to perform sexual acts or expose them to pornography without their consent. This also includes taking unsolicited nude, sexual videos, or sexual photos of the older adult survivor without their consent. There is a very large network on the internet of dementia porn that exploits folks in the older adult community that have psychological diagnoses and exploit that in a sexual way for money, drugs, or just sheer enjoyment for posting it on the internet. All of these things are done without consent. There are also caregivers that take photos of folks while they're changing, undressing, and toileting, and also sell those photos as well. So getting into some of the tactics that are used, and we're talking about intimidation and targeting vulnerabilities. This is one of the newer kind of spoke slices in the power and control wheel. We're talking about denying access to assistive devices, so that could include walkers, chairs, their glasses, hearing aids, dentures, and other assisted devices. They capitalize on the fears of police brutality and racial bias in older adult communities of color, telling them, the police will never listen to you, there's no point in going to court because they're not going to listen to you because of the way that the system is set up. and is inherently biased. Pressures the older adult, specifically for LGBTQ older adults, to come out to family, to come out to doctors, to friends, to nursing care staff, and really uses that as a bargaining tactic to get the older adult to do exactly what the person wants. And then also, this can include denying access to food, heat, care, medication, testosterone, hormone replacement therapy medication. Abusers that are using intimidation and targeting vulnerabilities can also refuse to follow medical recommendations and also refuse to dress the older adult inappropriately, either for the weather or regarding their gender expression. So those are also some really critical tactics that can be used in this life. So when we're talking about emotional abuse of older adults, this can include threats to withhold hormones, like testosterone injections for transgender or non-binary older adults, or withholding other non-gender specific medication like insulin, painkillers, high blood pressure medication. They treat the older adult survivor like an infant instead of an adult, and this is something we'll be talking about a little later about using baby talk, treating them like they're a small child, and that also ties into the long-term psychological abuse that over time that you are demeaning somebody to the point where they don't think they are a functioning adult anymore. Threaten to destroy property, and this can include, withdrawing, destroying, or hiding important immigration paperwork, passports, ID cards, medical cards, and any sort of, documentation that's important to the older adult. And then they can threaten to put the survivor in a nursing home or an assisted living community, and remove them from their home to disrupt them aging in place. This can also include yelling, insults, calling them names, degrading, mispronouncing the older adult, or even dead naming, or refusing to use the chosen name of the older adult that fits their gender expression. These are all forms of emotional abuse. And it's also important to remember that all of these tactics are occurring in conjunction with the traditional tactics that we see on the original power and control wheel. The ones that we're reviewing today are specific to older adults and how this looks in this community. So there's always multiple layers of these things going on. So ridicule, values, and denying access to traditions is also one of the newer spokes that we integrated and adapted from NCAL. What this looks like is destroying spiritual or traditional items of importance like icons, destroying or limiting access to ceremonial traditions, practices, church, prayer, as well as ignoring cultural practices or being respectful intentionally towards cultural practices. Abusers that are utilizing this tactic can also actively pray against the survivor, be very vocal about that, and defines spirituality as a masculine kind of trait and uses that kind of exploitation of heteronormity against the survivor as well. And they also can use religion as a threat. God doesn't allow divorce, so you can't leave me. These are all ways that this can present in older adult relationships as well. So isolation is one of the largest issues that face older adults. So whenever we have these tactics presenting, what it looks like is controlling all the interactions. So who they see, what they do, where they go, who they talk to. Canceling important appointments or plans on behalf of the older adult without their consent. So what that could look like is, one of the abusive children can call the shelter and cancel a counseling appointment and say, oh, they're sick, they're not coming, without the older adult knowing. Canceling appointments, so medical appointments, any sort of treatment that they are seeking. Also limiting access to technology, so email, phone, physical mail, completely cutting them off, as well as ignoring them. So purposely does not visit them or purposely doesn't talk to them or make contact with the older adult survivor, intentionally cutting them off so they're completely alone and only dependent on the abuser. So when we're talking about using family members, this one looks a little different from the traditional wheel because that one focuses on children specific. This, goes a lot broader because our domestic violence definition covers our family. And because there's an older adult, there are children involved, but not young children. So the way this would present is excluding family or denying access to the family. So the older adult, is not able to talk to their family or be able to see, grandchildren, nieces, nephews, children, even if it's their partner, denying access to their family, misleading their family members about the extent and nature of the older adult's condition, never letting them, if someone calls and asks to talk to the older adult, saying, oh, they don't want to talk right now, they're fine, everything's okay. Or if there's medical things going on, saying, the doctor said everything's fine, just keeping the family out of the loop. And then forcing family to either keep secrets from the older adult survivor or keeping secrets from the family about the survivor. So again, what this does is a tactic that's being used to kind of wedge between the older adult survivor and the family. So when we're talking about privilege, we're talking about the abuser speaking on behalf of the older adult, either at financial or medical appointments, which takes away the agency of the older adult, whether they're perceived to have it or not. The abuser takes on the voice for them. They make all the decisions without the consent of the older adult. Again, this plays into the psychological tactic of you're not able to do this, you are not independent, you need me here, this is why I'm here, I have to do this for you. And then taking advantage of their powerful stance in the community to use over the older adult. So what this could look like is in terms of, their racial power stance, their sexual orientation, gender, their economic status, or their class, using all of those things against the older adult and their identity as well. So when we talk about economic abuse and financial exploitation, this is the largest tactic that's used in this population. So when we're talking about economic abuse and financial exploitation, again, this is the largest tactic that's used in against this population. When we're talking about this, we're talking about misusing the older adult's money, property, or assets, abusing and or exploiting their power of attorney or guardianship rights, withholding benefits like Social Security, and using finances as a coercive bargaining tool for daily care, food, daily living, things like that. So when we're talking about financial and economic abuse and exploitation, abusers, will steal money, titles, or possessions. They also can operate under the liquidate, isolate, medicate mentality, where seniors, older adults are sedated and either locked in assisted living facilities or in their homes while their assets are being spent down by the abuser. And when we're talking about medicate, we're talking about forced medication to render them essentially comatose rather than, you need to take your meds today and staying on schedule. It's used to render the older adult comatose and more vulnerable to what the abuser is asking. This can also include legalized racketeering and includes benefits trafficking. PCAR and PCADV did a human trafficking of older adults webinar, which is on our website, where we cover some of that. So if you're interested in that, that's on there. So what that would look like is stealing and selling benefits cards, food stamps, Social Security, Medicaid, veterans benefits, or holding them over the older adult in exchange for, money, sex, drugs, and engaging in that type of commercial activity. And then also they can withhold these benefits from the older adult in order to get something from them. If you don't do this, I'm not going to give you your food stamp card this month. You will not eat. So this is something that we see a lot with the financial abuse in terms of the domestic violence in older adult populations. When we're talking about coercion and threats, we're talking about threats to leave and never see the older adult again, threats of homicide, threats of suicide, and this could either be against pets or livestock. We do live in Pennsylvania, so we do have a lot of farms and farmland, so they could threaten to harm livestock, which is also playing into economic abuse because that is how a lot of folks generate income. Then they can also threaten to institutionalize the older adult. If you don't do this, I'm going to put you in a home or I'm going to make you go away and disrupt them aging happily and healthily in place. Are there any questions on the new wheel? Hopefully you will use it as a great resource. It's so exciting. All right. So how can IPVILL present in older adults? What are we looking for? It can show up as physical, financial, and environmental. When we're talking about physical, we're talking about unexplained bruising, a lack of hygiene, seeming over or under medicated. Again, this isn't, somebody's having a reaction to their medicine. This is somebody that is literally rendered comatose or unable to communicate or function because they're being force-fed medicine. We're talking about signs of financial abuse. We're talking about an unexplained lack of funds and unable to pay bills when there were no previous problems. So if you're working with somebody who, goes out to the grocery store and is telling you, like, I don't know what happened, my card got declined, this has never happened before, or all of a sudden they're struggling to pay bills or they're not able to pay rent or pay their mortgage or whatever that would look like, this could be a flag for financial abuse occurring. And we're talking about environmental in terms of missing medications. So again, folks can take medications from older adults that they need and sell them, as well as a sudden pull from enjoyable activities, as well as missing or broken medical equipment. All of these things are ways that abusers, utilize these tactics and ways that we can pick up on them when we're working with older adults, whether it be through counseling services, for PFAs and in court, and even in shelter. So now we're going to shift gears a little bit, and we're going to talk about implicit bias, because whenever we're talking about older adults, we have a tendency as a society and as a system to look at these folks differently. So when we're talking about implicit bias, it's describing the automatic association that people make between groups of people and stereotypes about those groups. These automatic associations can influence behavior, which lead to biased interactions, even when they're not intentionally prejudiced. So as a society, again, there are gross misconceptions, assumptions, and attitudes towards adults that are 60 and older. So this increases the need for inclusive, accessible, and visible service for older adults. So why is this happening? There's a perception that older adults have less agency. There's deeply ingrained ageism in our system, and they're perceived to be at greater vulnerability because they're more likely to engage in systems, which puts them at the potential for higher injury. They also can be compounded with cognitive issues and diagnoses, mental health, more medication. There are barriers for reporting, and the venues where they frequent are also very siloed, so systems have a hard time talking to each other. So what this could present as talking down to or using baby talk to address older adults, constantly calling them hun and honey and granny, using terms like little, old, cute, or senile, like, oh my God, they're so cute, I want to put them in my pocket. Not appropriate when we're talking about an older adult. Not appropriate when we're talking about anybody, because everybody has their own agency. Also, assuming the older adult has no agency, just because you know what their age is, it doesn't mean they aren't able to make their own decisions about their care, their needs, their wants, and especially their story about what's happening to them in their relationships. Also, this could show up as assuming that all older adults are asexual. That may very well be true because that is a valid identity to hold, but older adults have sex. Everybody has sex. For folks that do engage in it, it happens. It is not something to assume, and it can be very harmful to make that assumption about older adults. And again, equivalating all older people to either grandma or grandpas. Oh, I saw this little grandma at the store. She was so cute and precious. That's not an appropriate way to talk about older adults. So a way to combat that is having an awareness of your own bias, prejudice, and knowledge about the people that we serve and their cultures are small ways to avoid imposing your own beliefs onto others. So being able to recognize when you're having these thoughts, because it's natural, it's going to happen, because, again, of the way that the systems are structured and how we've been functioned to see it in media and everywhere around us, right? So being able to unpack those as they pop up in your mind or as you hear them, trying to talk through that with coworkers or doing some self-talk to try to move away from a lot of these things. Now we're going to do a small scenario, and we're going to look at Lee's story. So Lee is a 71-year-old adult who contacted the hotline at your program. They're being abused by their grandchild. Lee was encouraged by their adult child to contact the program and brought Lee to the shelter. Lee's grandchild lives at home with them. After the intake, the advocates were discussing Lee.
Lee was abused by their grandchild. They don't fit the definition of domestic abuse. We should call elder abuse services.
I talked with Lee last night. They seemed very confused and just kept crying. Are you sure they don't have Alzheimer's disease?
Wow, 71. They don't look that old.
They probably are not going to want to stay here.
We don't have anyone to provide care for Lee. Did you see all the medications they take?
They are probably very nice.
I'm sure they're set in their ways. They will never make any changes. They will just keep letting their grandchild live with them.
I bet they're going to want to talk and talk. How are we ever going to find the time for them?
This will be great. They can help us take care of the kids. It would be nice to have them as a grandparent in shelter.
Lee comes out to the shelter where all the staff are talking.
How are you doing today? Did you eat your breakfast?
To save some time, we have worked out this nice service plan for you.
Wow, you don't look 71. You look great for your age.
There are not many services for someone your age. I have to call older adult protection services. They're the ones that can help you.
I bet we can find a nice nursing home where others will take care of you. Wouldn't you like that?
We have to hurry along now, honey, or we'll be late for our next appointment.
Okay, so after talking through Lee's story, what are some of the things that you have heard before or have said yourself regarding older adults that are seeking our services? Or what kinds of comments did you hear that might be meant as compliments that can actually be hurtful or offensive to Lee? And please use the chat box. Yeah, I saw, yikes, you don't look like you're 71. Infantilizing language and tone. Did you eat your breakfast? Older home for you. Not going to want to stay here. There aren't services for you. We don't have services for your age. These are all great. Speaking to Lee as if they're a child and that they can help with the kids. Yes. Assuming, again, that all older adults are grandmas and grandpas, and that is a role that they are predestined to assume. Diagnosing Alzheimer's. That's often frequent whenever we're talking about older adults. It's always assumed that they have dementia or Alzheimer's or something else is going on, when in reality we could be witnessing trauma responses from folks, that are having difficulty recalling their story, or the story changes. Again, we know that that's a trauma response, but because this person is aged into a category, we instantly are able to make the assumption that there's something cognitive occurring as well. Yeah, come along, sweetie. We don't want you to be late. Again, that's talking down to the older adult, infantilizing, using that type of language, and again, taking away the agency from Lee, that Lee is an older adult, and again, able to make their own decisions, and the assumption that we can't take care of them because of the meds. As we all know, we do not administer meds in our programs for folks that are staying in shelter. That is all up onto the survivor to take as they need. That is completely up to them. So it is not our job to police the needs of anybody in shelter, especially older adults that may or may not come with medication. So what kinds of assumptions were made about Lee that may not have been made about a younger survivor with similar circumstances? And please use the chat box. These are great. Assume that another program would be able to help them more than DV. And that's important, and that's going to be one of the best practices that we talk about, is providing a holistic approach to our method, because we are the DV experts. If domestic violence is occurring in a relationship, we can work with other agencies together to serve them in the best way while still providing our services, because Lee, in this case, would obviously benefit from any of our programs that we offer. That they could be, oh, sure. So the question is, what assumptions were made about Lee, because as a 71-year-old adult, that would not have been made about a younger survivor coming with the same story as Lee. They could be wrong about their situation or abuse. Yep, talking about how this didn't really happen. Again, we know that our definition of domestic violence is inclusive of family members as well, not just partners, intimate partners, spouses, current or former. So that's also important. That it couldn't happen at their age, again, undermining the disclosure of abuse that's occurring. That's a great point, that we shouldn't be assuming anything anyways, and that is the whole entire point. So thank you so much for that. Yeah, if it was a younger survivor that was presenting, we wouldn't be talking down to them like they're a child. Credibility due to their age, yep. Suggesting that the adult child call the AAA. That's a good alternative to the way that the advocates were talking about them. Credibility, that needing caregiving means that they can't be empowered. Right. So none of the advocates had shared that, they talked with Lee and that was a need. That was not necessarily an identified need by Lee saying, I need assistance with daily care needs. Again, because we see the age on the paper, we make the assumption that this individual is going to have these issues and is unable to do it on their own. So that's great. How many of you have heard or even said some of these things about older adults regarding our services? I'm not going to make you put that in the box or ask you to put that in the box. It's just definitely something to think about when we're talking about older adults. That yes, the overall theme is we want to treat them like everybody else, right? But we also have to identify there are also needs that exist because the tactics look different, but our approach should be still similar, where we don't talk down to survivors, we don't take their agency away, we don't question their stories, so that's a really important point to take away from this. It's also important to know that our subtle and not so subtle agencies that came out in the exercise that can be perpetuated are important to recognize. It's our job to learn about factors that might be unique for older adult victims as a result of the aging process and to treat all survivors with respect and dignity. So when we're talking about best practices, we want to combat assumptions and challenge ageism. So not to assume all older adults are frail, mentally incompetent, or asexual. We want to build agency capacity. We want to request staff trainings, update program literature to be inclusive of and accessible for older adults. In terms of when you do resource development, having options that are larger print, being cognizant of what type of material these are printed on. If it's glossy paper, it might be hard for folks with dexterity issues. This is inclusive of this age range, but just in general, trying to use like a heavier paper that's easier to use and open for folks. And also putting them on your resources. So when you're building trainings, use pictures of older adults. Be inclusive of that and be mindful when you're having conversations to include some of the tactics of abuse that older adults are facing in domestic violence relationships. It's also a great best practice to expand your outreach and education to venues that are frequented by this population. So seeking out public libraries, senior centers, dentist office, podiatrists, reaching out to Meals on Wheels. All of these types of relationships can be built and seen as a prevention method for older adults, but also PCADV's IPVILL kind of agenda is actively looking at prevention for the population of 45 to 59, and then focusing on IPVILL, which is 60 and older. So this is a great way to kind of merge those two, as well as develop a working relationship with your local area agency on aging. They are represented in every county throughout the state. PCADV has a really great relationship with aging at the state level. We're working on them again on a human trafficking project. We're doing some co-branded resources and posters that will be sent out to programs, both in aging and domestic violence agencies. So you'll be seeing that on our level, but it's important, again, going back to Lee's scenario, it would be a great way, somebody also mentioned in the chat, to reach out to AAA and see how we could work together and see what resources that we can come with together. Plus we have confidentiality, which is great. And then also to cross-train your staff when you build these relationships. So get cross-trained so you understand each other's agencies and the services that you're able to deliver, because that will help you to develop a referral process, a warm referral, in order to collaborate, to establish memorandums of understanding, and also task forces, elder abuse task forces throughout the state, where it's a multidisciplinary team where they come together and talk about these specific issues regarding older adult abuse. And having domestic violence at the table is critical, again, because we use the elder abuse umbrella terminology so frequently, the victimization of domestic violence gets lost. So having experts like you at the table is really important as well. are there any questions? Please use the chat box. PCADV, again, has developed this Intimate Partner Violence and Later Life Wheel. So that is free for you to use. If you need another copy, please reach out. They're available to download. And then we also have a one-pager where it kind of just reviews IPVILL and some of the generalized tactics and what it looks like, as well as the evaluation. So there's a question about, are there thoughts on how to provide service to older adults who have transportation limitations? So again, that could be something that would come out of a relationship with your local AAA, because they do offer those types of resources. And also depending on what type of insurance, if this person has insurance, they are able to get like med van, free med rides. And a lot of them are also accessible for folks that have mobility issues. That's a great question. Thank you. Rover, yes, thank you. County assisted transportation, yep, reaching out to the county. Home delivery medications. Any advice for older adults dealing with payee financial abuse issues? So when we're talking about something that rises to that level, that is something where protective services are experts. So reaching out to them and talking through, again, in generalized way, unless you have a consent form, to reach out to them to talk about what sort of investigation can be conducted in order to pursue legal action, because that is kind of beyond our realm to actually pursue pay financial abuse. But in terms of, advocacy and support, you can do accompaniment, you can do your research on what that could look like, being supportive and talking them through it, reassuring that this isn't just something that happened to them, that this is something that happens very frequently, and just validating their experience. Are there best practices to safeguard confidentiality with clients who may have caregivers? So whenever you're talking about confidentiality with caregivers, do you mean with them being in the room while you're working with them? Can you clarify? Where can we find APS elder abuse reporting requirements? Those can be found on the aging website on pa.gov. They have their own website for APS, Adult Protective Services, and Older Adult Protective Services, where they go through exactly what that would look like, because folks at aging are mandated reporters of elder abuse, which is also something whenever you're building these relationships to be aware of, that we are not, PCADV, DV programs are not mandated reporters for elder abuse by the statute that they are. Okay, so in general, if we're talking about caregivers who want to be informed about everything and need to be in the room, again, that would default to the survivor, and using some advocacy skills to kind of triage, having the caregiver, oh, do you want some water, and trying to get them immediately away from the survivor to ask, are you comfortable with them being in the room? Do you want them to be? And if they are, having them sign a confidentiality form so that they can be held to some sort of standard so that the survivor can feel comfortable. If you are not able to triage them, getting them away from the survivor and they need to be in the room, that could be also a conversation. Holding space around, this is going to be a confidential conversation. If you would be comfortable leaving the room, I would like to talk to them in private, and kind of seeing how that plays out for them. We do have some upcoming events for our training team. So these are some of the trainings that are also upcoming from PCADV. On the 10th, our manager, Katie Taylor, is going to be doing the Systems Advocacy Basics training for Columbia-Montour County. On the 24th, Michelle Cooper, our health education specialist, is going to be presenting on traumatic brain injury and the health screening tool. It's a webinar from 2 to 3. If you want to email her, her information is there to get a registration link. On the 25th and 26th, Bucks County is going to be receiving an organizational and vicarious trauma training from Katie and Michelle. And then on the 27th, PCADV will be at Central PA Pride Fest. We are going to have some brand new swag and resources, including a pronoun card and a bifold brochure specific to LGBTQ intimate partner violence. So those are something exciting to look forward to. So we wanted to share those with you. And then if you have any questions for me, this is my contact information. I am the IPVILL specialist here at PCADV. My phone number is here, my email is here. Please reach out if you need any sort of resources or have any training ideas specific to older adults. I would be more than happy to help. All of our resources are free to you. We can develop any training that is why we are here. So please reach out. We are super excited to hear from programs and the work that you're doing, and we love to highlight that as well. So thank you, everybody. We're going to end a little early. I appreciate everyone being on here and learning about IPVILL, and there will be more to come in the future. Please remember to do the evaluation if you get a chance. Thank you so much, everyone.